Welcome, everyone. This is Alan Wong. I'm your president of the American Academy of Developmental Medicine and Dentistry, and I'm here to welcome you to another wonderful presentation, one that's very engaging, one very collaborative. We have a panelist of exciting speakers to help us serve our IDD community better in our practices, wherever they are. I'm just so excited to have such a exciting panelist, and I'm going to introduce Ademilola, who is our virtual grand round facilitator and finishing her third year in medical school, right? Congratulations to you. Right on. And explain what virtual grand rounds are and and introduce our guest. So on behalf of AADMD, thank you for being with us here tonight. Ademilola.
Thank you, Dr. Wong. Welcome everyone to our May 2022 virtual grand rounds. My name is Ademilola. I'm a third year medical student at University of Louisville School of Medicine. I'm this year's AADMD virtual grand rounds coordinator, but I'll be filling in for Cindy Lee, who's our facilitator. For those of you who are new, virtual grand rounds are a webinar-based presentation model that creates a space for mentorship and exchange of knowledge and experience between seasoned IDD providers, entry-level clinicians, and future healthcare providers in training. The purpose of the grand round session is to expand and strengthen the IDD healthcare workforce across the spectrum of experiences. Thank you so much for joining us tonight. Before I start, I wanted to hold about 20 seconds of silence for the victims of the Buffalo, New York shooting, if you all would join me in that. All right, thank you so much for doing that. I think it's important to kind of bring those issues into these spaces because I think it affects everyone. So thank you for joining me in that. If you have any questions throughout the webinar, please write your questions in the Q&A box on the sidebar. Any unanswered questions we'll answer after the webinar, but just remember to continuously ask questions through that Q&A box. Now I would like to introduce our amazing VGR panelists for tonight. We will be discussing environmental adaptations to increase comfort for individuals with ID/IDD at the dental office, as well as medical care settings. So the first speaker I would like to introduce is Dr. Janice Tona. She is an occupational therapist and educational psychologist with over 30 years of experience. She holds a BS in occupational therapy from Utica Colleges of Syracuse University, an MS in Pediatric and Developmental Disabilities based work from the University of Pittsburgh, and a PhD in Educational Psychology from the University at Buffalo. She is a clinical associate professor and OT program director at the University of Buffalo and has been collaborating with the University Pediatric Dentistry since 2014. Next, I would like to introduce Deanne Wells. She is a board certified pediatric dentist who takes a special interest for care for patients with disabilities. Her undergraduate degree is from Howard University, and Doctor of Dental Surgery degree from UB School of Dental Medicine, where she has been faculty for over 20 years. Dr. Wells currently holds the position of secretary for the AADMD board. Now introducing the students that will be joining us today. We have Heidi Kyle, who is a graduate student in the BS/MS Occupational Therapy program at the University of Buffalo. She is currently completing her first level 2 fieldwork at the University Pediatric Dentistry. She is a member of the AADMD and will be attending the AADMD conference this June in Orlando. Next, we have Meredith Wheelock. She was a graduate student at the University of Buffalo in the BS/MS Occupational Therapy program. She is also completing her first level 2 fieldwork at the University Pediatric Dentistry, and she will also be attending the AADMD conference this June as a member. Last but not least, we have Simone DeBellis. She is a third year dental student at the University of Buffalo School of Medicine. She is from Rockville Center, New York, and graduated from Binghamton University in 2020. Simone is actually the president of the UBSDM chapter of AADMD and is incoming assistant chair of the AADMD student resident community. Thank you so much for joining us today. That being said, please welcome our VGR presenters for tonight.
Thank you very much, Ade. Hopefully everyone can hear me well. As she said, I'm Dr. Deanne Wells, and I'm going to be talking to you and introducing our students and moving on with our topic. I first want to tell you about our pediatric dental department. We have been treating patients with disabilities for over 25 years, and it's always been a work in progress. As with every other program, the goal has always been to assure the clinical treatment results in best outcomes. And so for those of you familiar with dentistry, you understand that that involves a careful placement of instruments in a highly vascular area that can be easily compromised with the airway, correct? And sharp instruments as such too. So it's a challenging aspect when applied to treatment of all patients, and especially those with disabilities. So naturally, our goal has always been to provide treatment and provide dental professionals who are welcoming and accommodating, but most importantly, proficient. And even before CODA's new guidelines, we have been trying to assure that the dental students and the residents, all of the providers, are able to manage that treatment in a safe and comfortable environment. And also that they're excited by the service that we're providing and by the relationships that we're forming with the patients, so that in turn, when these students and residents graduate, they will create the right environment in their workplace. Collaboration with other disciplines can help provide that right environment. So let me tell you the Buffalo story that led to this collaborative program between occupational therapy and dentistry. In 2013-2014, an occupational therapy student who is a clerk in our dental office asked her instructor if the techniques that she was learning in OT could be used to help the patients with disabilities that she was seeing in the dental office alongside us. That student was Molly DiMatteo, and that instructor was Dr. John Tona. From there, developed a relationship between dentistry and occupational therapy that included linking the AADMD student chapters, many attempts to run programs together, but they were always both so busy. And eventually, Dr. Tona's dream, the placement of OT students and their structured fieldwork curriculum right in our dental offices. And this was done to provide support for the challenging aspects that we spoke about of patient care. So since then, we have currently hired our very own occupational therapists. Now, in addition, we teach courses in the dental school, and we asked OT to design an introductory course for the dental students. The course is entitled CLD 822. And this is a course that's designed to prepare the second-year dental students for patient care in the clinic. For us, the interest, of course, is a population with disabilities, and so the focus is care for patients with disabilities. Before COVID-19, the course involved a tour to the Museum of Disability History, which was here in Buffalo, New York. But as a result of COVID-19, that museum closed down, and so we had to redesign the course. With OT already embedded in the dental clinic and seeing how beneficial that collaboration was for patient care and for dentistry, it was just a natural and perfect transition. So students have reported that having occupational therapy introduce the topic of patients with disabilities has been valuable. And I'm hoping that today the students and Dr. Tona can share that information with you. So if we move to the next slide, for today's session, we plan to briefly discuss the needs in individuals with IDD in dental, and it can be applied to medical settings. And then we'll introduce you to the field of occupational therapy. Our occupational therapy students that are on with us today will tell us about some considerations for sensory motor and behavioral challenges. and give us some tips in those areas and with our environment. And then our dental student, Simone, will let us know about a Give Kids a Smile inclusive program that she developed with us and with the OT students this year. And take a look at this picture. Welcoming you here today is our patient, Ryan, who is in our OT sensory waiting room, getting ready for his dental appointment. So this is a good opportunity to talk about challenges of the dental appointment and challenges affecting oral hygiene. Individuals with intellectual and developmental disabilities, and in particular those with autism and Down syndrome, often present with much difficulty tolerating sensory input. This makes for challenges in the dental office with our bright lights, our loud drills, our continuous touching of the patient's mouths, and I spoke about sharp instruments, right? And the same is true, many of this can be applied to medical appointments such as ENT and women's health. So individuals with cerebral palsy and muscular dystrophy, they generally have more motor difficulties in addition to the sensory challenges. And this makes it difficult to get on and off of an exam table in a medical appointment or into and out of a dental chair. And the patient is often in a position that is not relaxed, which only serves to increase their muscle tone and make it difficult for them to open their mouth or move a specific body part in a dental or medical exam. These individuals often exhibit poor motor control and sensory defensiveness to new stimuli, such as unfamiliar textures and unfamiliar tastes. Individuals with IDD usually have a propensity for soft and sugary foods, which contribute to their poor oral hygiene. With the barriers that these individuals may have regarding dental hygiene, it is important for dental practitioners and other healthcare professionals as well to be educated on treating these individuals so that they can receive the best individualized care in the most appropriate environment. And so I'll let Dr. Tona tell you a bit more about occupational therapy. Dr. Tona, unmute. There we go.
Thank you, Dr. Dion. Sorry about that. So how does an occupational therapist help with all of this? Well, occupational therapists help people to engage in activities of daily living, the things that are important to the things that occupy our everyday lives. And those are things like oral care, which is really necessary for maintaining health and well-being on a day-to-day basis. Another activity of daily living is going to the dental appointments or a doctor appointment and maintaining your health in that way. And the way that we help people to do this is by analyzing the person, the environment, and the occupation or task. So we're constantly looking at these three things to figure out what we need to modify to get to this just right section in the middle, which is when they can really perform that occupation well. So we try to figure out, like, do we need to modify the person? For example, do we need to make their hands a little stronger or their arms a little stronger to be able to do that activity? Do we need to help them to open their mouth a little wider? Do we need to modify the environment? And that might be something like dimming the lights in an exam room or putting a wheelchair ramp in or something along those lines. Or do we need to modify the occupation? Do we have to change the way they do something? Maybe they need to use an electric toothbrush instead of a manual toothbrush, for example. So we're always looking at that. We're always looking at the person, the occupation, and the environment and deciding what needs to be modified. Now, occupational therapists are very knowledgeable about the sensory and motor needs of individuals with IDD. And we really have extensive knowledge on the different types of developmental disabilities and the challenges that come with treating individuals with IDD. OTs are able to provide knowledge to dental practitioners and other healthcare providers on the best ways to care for individuals with IDD in the dental and medical setting. We can really modify the dental or medical office. We may suggest changes in positioning of the client or modifications to the tools that are used, such as a toothbrush, for example. Working together, OTs and dental practitioners and other healthcare providers can make a really big difference in the lives of those with IDD, and we can help our patients and clients to receive the care that they really deserve. Now, I'm telling you this, and I've been an occupational therapist for a long time, and I've seen it in practice, but we really have evidence now to show that collaboration between occupational therapy and other healthcare providers is beneficial to the patients. Dr. Sharon Cermak and colleagues from the University of Southern California have been busy studying sensory adapted dental environments. And they've been doing this since around 2015, I think was their first study. They've had a few national well-funded studies. They work at the Children's Hospital of Los Angeles. And they've really shown that modifying the dental environment by doing things like dimming lights or providing firm pressure with a big butterfly that they use to hug the kids really reduces anxiety in children with autism. And the children need fewer hands to hold them down. And there's actually electrodermal results that show that there's decreased anxiety. And in addition, there's also decreased anxiety in children without autism. So everyone seems to benefit from this sensory adapted dental environment. And that's something that we should really consider. So now I want to turn it over and introduce you to Heidi Kyle, who's going to talk to you a little bit about motor and positioning.
Okay, hi everyone. So let's talk about some motor and positioning. Individuals with developmental disabilities often have difficulty swallowing and are at an increased risk for aspiration. This is particularly true for individuals who are observed to have drooling and difficulty managing their saliva. Therefore, practitioners must be aware of pooling of saliva, especially if a patient is completely horizontal. You must suction the patient's mouth regularly throughout the visit. As a rule, it is best to avoid neck extension beyond neutral during a dental exam. Extending the neck reduces epiglottis protection of the airway. It is best to keep your patient's neck in neutral or slight flexion with a slight chin tuck, and be sure to gently suction the mouth to keep it clear of saliva. Let's watch Dr. Dion introduce suctioning in a way that is safe and fun. Individuals with developmental disabilities often have differences in muscle tone that may interfere with a dental office visit. Muscle tone is the muscle's underlying readiness to contract and perform movement. Some patients you may see, like those with cerebral palsy, may have high or low tone. When a patient has stiff limbs, this is often referred to as hypertonia. An increase in muscle tone makes it difficult for a practitioner to move their patient's limbs. Spasticity is when there is an increase in resistance when moving an extremity in one direction, such as only flexion or extension. Muscle tone can be velocity dependent, which means if you move a patient too quickly, their tone can increase. In order to avoid this increase in tone, you should move a patient slowly when positioning them in the dental chair or onto an exam table. The child in this video has spasticity. As you can see how tight his bicep muscles are when the therapist tries to straighten his arm. This child has spastic quadriplegia, so all four limbs are spastic, even though we are only showing you the bicep. In this child's case, his neck, head, and trunk are also involved. Rigidity is when there is an increase in muscle tone resistance in both directions, such as flexion and extension. When a patient presents as loose or floppy, this is referred to as hypotonia. Hypotonia is a decrease in muscle tone. Individuals with Down syndrome often present with low muscle tone, and they may have trouble holding a position for a prolonged period of time against gravity. Children with Down syndrome are also at risk of having neck instability, so it is important to provide support to the head and neck during the exam. In this slide, we see a boy with hypertonic cerebral palsy on the left. We can see that he has a great deal of trouble conforming to the position of the chair, and the chair does not support his body adequately. This will make it difficult for him to relax and open his mouth. On the right are two different young men who are both wearing red shirts, who have Down syndrome and lower muscle tone. They are able to conform to the chair, and their bodies fit the chair well. They are fully supported and able to relax. Appropriate positioning in the dental chair can relax a patient and prevent muscle tightness or injury. When a patient does not have postural support, they might pull their arms into their body and clench their jaw. We all need proximal stability, good trunk support, before we can have distal mobility, including mouth and tongue movements. When we do not have good proximal stability, we tend to clench our fists and our jaw to help stabilize our body. So it is extremely important that you make sure your patient is well supported in the dental chair. One way to remember this is before you touch the lips, you need to fix the hips. The individual in this chair does not have high muscle tone and is well supported and well positioned. Now let's look at this child with spasticity or high muscle tone. You can see in the first picture that his body is not able to relax in the dental chair. Even when he is helped to lay back in the chair, his body is not aligned as his hips are not in the proper position. His back is curved and not lying flat against the back of the chair, and his head is not at the level of the headrest. There are several devices you could use to help a patient to relax and be properly positioned in the chair. One is the stay in place, which is a beanbag-like device that allows you to comfortably position the child. An Olympic vac pack is also a beanbag-like device, but the practitioner is able to suction the air out after positioning the patient, creating a firm but well-molded positioning device that's unique to each patient. When positioning a patient, you should have their head in midline and slightly flexed forward. The body should be in alignment with arms towards midline. The patient's hips and knees should be slightly flexed and flexed more towards 90 degrees if the patient has high tone. In Sebastian's case, we use the stay-in-place cushion. As you can see, Sebastian is much more relaxed in this chair and able to focus and open his mouth for the exam. Each individual with spasticity is unique, and it may be best to work with the individual's occupational or physical therapist when first determining seating modifications for the dental chair. If a patient has high extensor tone in their legs, their lower body may appear very stiff and straight in the dental chair. One way to break up this high extensor tone is to put a wedge or roll under the patient's knees to place their hips and knees into flexion. In Sebastian's case, we use the pool noodle under the stay-in-place cushion to give him some hip and knee flexion. Facilitating this hip flexion will decrease your patient's overall tone and help with core stability and mouth opening for the patient. No matter what the tone of the patient, you should ensure that the patient's head and trunk are always well supported. And increasing core stability and support will help when facilitating mouth opening. Now let's talk about primitive reflexes. Primitive reflexes are present when a baby is born, but generally go away within the first year of life when they are integrated into voluntary movements. Individuals with IDD often present persistent primitive reflexes well beyond the first year of life. Let's talk about these 4 reflexes that can interfere with the dental exam. The asymmetrical tonic neck reflex, or ATNR, is stimulated by the individual turning their head to one side. When this happens, the arms and legs on the face side extend, and the arms and legs on the skull side flex. When placed in this position for an extended period of time, individuals can become uncomfortable. It is best practice to keep the individual's head in midline whenever possible during an exam. The tonic labyrinthine reflex occurs when an individual is fully reclined to the horizontal position. The response is increased extension of the entire body. This can lead to discomfort for the patient and also make it difficult for the patient to open their mouth. It is best to treat the patient in a semi-reclined rather than fully reclined position for this reason. There are 2 tongue reflexes that are similar and can be difficult during dental exams. The tongue thrust is elicited when the tip of the tongue is touched, and the transverse tongue reflex is elicited when the side of the tongue is touched. In both cases, the tongue moves towards the stimulus to either thrust forward out of the mouth or move laterally towards the side of the stimulus. The best way to work around a tongue thrust or transverse tongue is to avoid touching the tongue during exams. You can also use the principle of transverse tongue to your advantage by touching the side of the tongue to which you want the tongue to move, not trying to push the tongue away from a side. The tonic bite occurs with stimulation of the teeth or gums and can result in forceful clenching of the jaw for some patients. The best response if this happens is to release the pressure on the instrument and wait for the patient to open their mouth, then remove the instrument. If a patient has a strong bite reflex, it should be noted in the chart, and a bite stick or mouth prop should be considered for future visits for the patient's safety and to avoid damage to the teeth. Now I'll turn it over to my OT student colleague, Meredith Wheelock.
All right, hi everyone. Now let's talk about how our sensory systems may impact a dental or medical visit. Human beings are constantly taking in sensory information from our eyes, ears, nose, mouth, skin, and even from our inner ear, known as vestibular input, as well as small muscle spindle receptors that tell us how tight our muscles are and help us to know where our body parts are in space, or proprioceptors. We use this information to decide how to interact with the environment. Should we be relaxed or tense? Should we move or sit still? It is important to remember all of the 7 senses when working with patients who have a developmental disability, as they may be affected by one or all different types of sensory input. Many individuals with IDD process sensory input in ways that are unique to themselves and different from the ways that you might process sensory information. Some of our patients have a very high threshold and can tolerate a great deal of stimulation without becoming upset. In fact, they may seek some stimulation and be constantly on the move, rocking, touching things, and enjoying bright lights and loud sounds. Other patients are just the opposite. They have a low threshold and respond very quickly to even slight stimulation. They may have sensory defensiveness, which is an emotional response to stimulation that would not bother most people. This can result in a fight or flight or freeze response, which may result in the patient attempting to leave the room or becoming combative or just freezing in place and refusing to open their mouth or move. The best way to manage sensory differences is to understand them ahead of time and prepare for them in your appointment. We have found that a phone call a day or two before their visit or a survey for the family to complete before their first visit are very good ways to learn about sensory needs and to be prepared for the visit. We also keep a record of sensory needs and the patient responses in our electronic medical record, so we're prepared for the next visit. Some people have a high threshold for sensory input, so they do not react to sensory input as quickly as most people. This is often displayed as sensory seeking, and these individuals may not feel pain easily as they don't register the input. It is important to be aware of this, as these patients may not realize if something wrong is occurring. Often these patients appear fidgety or distracted as they are seeking stimulation. You may find that using small fidget toys, such as Nubby Dollar store toys, can be very helpful. Watching videos can also be helpful. A commercially available molar mount, pictured in on the right, allows a commercial tablet to be mounted on the dental light for easy viewing. Some dental health practitioners have also created homemade mounts, like the one on the left, for patients to watch a video on a cell phone. At the opposite end of the sensory spectrum, those who experience hypersensitivity tend to overreact to sensory input. Hypersensitivity often presents a sensory defensiveness, whereby the individual has an emotional reaction to sensory input that would not typically bother people. The lights, sounds, smell, feel, taste, and even the movement of the head as the dental chair lowers and raises can be problematic for individuals with sensory defensiveness. Some solutions for bright lights are to provide sunglasses for the patient and to use dental loops instead of using the overhead light. Noise canceling headphones or headphones with preferred music or video sound can be very helpful for auditory defensiveness. Concerning vision, bright and flashing lights, as well as the mask a hygienist may use to cover one's face, could result in an emotional or behavioral reaction. These children may often close or rub their eyes. To avoid this, you can allow the child to wear sunglasses to dim or block the lights, or avoid direct light into the child's eyes. By using a face mask that has a transparent shield, the child may become more comfortable while in the dental chair, and many children with autism tend to look at one's mouth rather than their eyes, so if they're using a clear face mask, they would still be able to do this. Touch is a sensation that can have a powerful impact. Individuals with sensory defensiveness often demonstrate extreme distress by light touch and have difficulty handling unexpected touch. Light touch travels through the anterolateral portion of the nervous system, which is also used for pain, and is associated with the sympathetic nervous system, which is very arousing and results in fight or flight. Conversely, deep touch and firm pressure is very calming as it travels through the dorsal column portion of the nervous system and is associated with the parasympathetic nervous system, which helps us rest and digest. It is important to always let patients know when and where you will be touching them and seek their permission whenever possible. One helpful tool for dental and medical settings is to prepare patients by applying deep pressure, starting at the hands and moving to the forearms, upper arms, shoulders, cheeks, and finally mouth, then providing deep pressure to the oral area before working in the mouth. Let's see what that looks like. Utilizing an X-ray apron or weighted blanket throughout the cleaning process for full body pressure can also benefit the client. You can also ask the family if they think the individual would benefit from a weighted blanket prior to beginning, since the family members know the individual best. One important thing to note is that if you choose to utilize a weighted blanket, it should only be 10% of the child's body weight. This should not be used as a restraint by any means, so the child should still be able to move freely with the blanket on them. Let's take a look at how a weighted blanket can help.
So here, it's hard to see, but he has a weighted blanket on under his little dental apron there.
We need to recognize that smells and tastes can also be challenging for our patients. Be sure to ask about preferred smells and tastes when working with your patients. Also consider the flavor of your gloves if you are working in a patient's mouth. Flavored gloves are available and can be helpful for some individuals. Vanilla and lavender are particularly relaxing scents, and there are vanilla and grape flavored gloves available. Now that we've gone over sensory processing, let's just take a few minutes to reframe the idea of behavior from being the way that someone acts to a means of communication. An individual who may experience vestibular dysfunction could demonstrate hypersensitivity to a change in head or body position. This may result in the patient becoming dizzy, nauseous, or fearful of the dental chair. A possible solution to working with a child who is hypersensitive or a sensory avoider when it comes to the vestibular sense is putting the chair in the reclined position before the patient gets into the chair to avoid the patient experiencing the unexpected backward motion. We find it helpful to bring these patients in between dental appointments to work with OT to help get used to the dental chair. In our patients, many behaviors are a response to the environment, possibly being overstimulating or understimulating. Behaviors can also be influenced by past experiences, such as difficulty at a prior dental visit, making them timid or causing them to act out. Behavior can also be a form of communication in response to the physical and non-physical environment. If we view behavior as a form of communication, we can understand that individuals who are able to express themselves verbally have less need for extreme nonverbal behavioral communication. When trying to determine the cause of an individual's behavior, a helpful trick is to remember the acronym MEATS. The M refers to medical causes, which may include illness, injury, psychiatric conditions, etc. This should always be ruled out first, as it usually has a sudden onset, appearing to happen for no reason. It may even be associated with a certain body position. The E stands for escape, as the individual may be demonstrating this behavior to avoid a task or demand. A for attention refers to the possibility of the individual seeking attention, whether verbal, social, or physical. T for tangible refers to individuals that may be seeking access to an item, service, or activity. And lastly, S for sensory, as discussed in the previous module, refers to the individual's behavioral response to the various sensory experiences in the dental office, such as the looks, smells, feels, and tastes. One reason that individuals may try to escape from a dental or medical appointment is due to past traumas. We must always keep tenets of trauma-informed care in mind when working with our patients, as we do not know what past traumas our patients have endured. Trauma-informed care provides universal precautions for mental health and well-being and can help to avoid difficult behaviors with our patients. The 5 pillars of trauma-informed care are safety, choice, collaboration, trustworthiness, and empowerment. When working with patients in dental or medical settings, safety might include having common areas that are welcoming and where privacy is respected. We have created a separate sensory-friendly waiting area for our patients who struggle with a noisy waiting room to be relaxed and to be in a private place where they can engage in behaviors that help them to calm. Choice might include providing a clear choice to patients and caregivers about their rights. For patients who are unable to make informed major decisions about their healthcare, Choice can be as simple as the flavor of the toothpaste, which chair they prefer to sit in, or how many seconds they keep their mouth open before they get a break. Collaboration can involve having patients and caregivers play as large a role as they are able in selecting their plan of care. Trustworthiness includes being clear and consistent. For our population, it includes showing and telling the patient what you are going to do and not having surprises. And empowerment includes recognizing the patient and caregiver and telling them everything they are doing well to stay healthy and encouraging them to continue and to build healthy behaviors. The occupational therapy students at University Pediatric Dentistry have created a sensory waiting room that we call the green room. Patients can wait in this area and enjoy calming sensory input, or they can practice skills to get ready for the operatory. We even have a room with a dental chair dedicated to practicing for the real operatory. Since behavior is a form of communication, it is not uncommon to see behavior problems in children who cannot communicate. For some of our patients, the spoken word takes the form of sign language, assistive communication devices, a simple communication picture board, or even specific gestures that the caregivers have come to understand as having specific meanings such as yes and no. Unfortunately, many of the individuals we work with IDD have limited verbal skills. Nonverbal communication can be clear, but often requires interpretation from someone who knows the individual well. Establishing a means of verbal and nonverbal communication early in the healthcare relationship increases the likelihood of successful future visits. Let's hear from Sujit, a motivational speaker, musician, son of 2 dentists, and man with Down syndrome, about how we can help individuals with disabilities to feel more comfortable in the dental office.
Because at least I have my parents, because they're my dental work. So I'm comfortable with my parents, but not only like to say that by going to the dentist, to the office, like at home, especially with my parents, but like it's how to what they want, how they want to get their teeth done, getting x-rays and cleaning, or like explaining different things what they need to use the tools by before explaining before you go to the dentist.
Oh, so you think it's really helpful if the family tells you before you go to the dentist, if they say this is what happened today, you're going to go to the dentist today and you're going to get an x-ray.
Yeah.
I think that's helpful to know ahead of time what's going to happen today. So one of the things that some dentists do is they have videotape, they watch online before you go. So you could watch like what happens at a cleaning, and it might show that the person going to the dentist office, you're going to go and you're going to sit in this chair, and it's an actual picture of somebody sitting in the chair. Like I took your picture the other day.
Yeah.
And then you're going to open your mouth and they're going to count your teeth, and they're going to put this, special tool in your mouth, and they're going to, put this instrument in your mouth and clean your teeth, and then showing people what it means to get an x-ray. Do you think it would be helpful if all of the dentist office had that online for people to watch beforehand?
Well, that would be great.
Some ways we have found beneficial for promoting positive behaviors are to set the stages for success by first doing a pre-visit survey, which can help dental health professionals to be prepared for new patients and the accompanying conditions such as differences in muscle tone or sensory processing before they arrive, in order to try to make the initial visit as positive as possible. It is important to schedule appointments to avoid halt situations at times when the patient is least likely to be hungry, angry, lonely, or tired, which will reduce the likelihood of disruptive behaviors. Another recommendation is to communicate throughout the session so the patient knows what to expect, using the tell, show, do method. In this method, we tell the patient what to expect by providing a verbal explanation of procedures and steps, Show the patient what to expect by demonstrating visual, auditory, olfactory, and tactile aspects of the procedure to the patient in a non-threatening way, and do the activity by completing the procedure without deviating from the explanation and demonstration.
Put them on just like this. Awesome. If you like, you can put your hand right over there to hold it for me. I always like that. Right here to hold that for me. There you go. Perfect. Awesome. Do you think it's important to put some glasses on you? You want some glasses for the light? Are you okay? What do you think? This is our mirror. I know this slides away a lot. We use this so that we can count your teeth, like we count your fingers. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. And we'll do the same thing for your mouth. So we'll be nice and wide. Let's see if I can just slide my mirror on the side first. So I would usually do that. I don't know if that's helpful. I go to the side instead of going straight in. You know, I just feel like it gives me a chance to slowly make my way where I want to go. Good. Let's try the other side and see how you do. Awesome. Good job. Good job. Now I'm going to get my Explorer so I can show you for counting. I like to tell my students to count with this side first. 1, 2, 3, 4, 5. Before going in with the pointy side that kids are really worried about. And for me, we go from behind. So that does cause, like I always realize when I do that, they get a little anxious, like right? Because I suddenly disappear.
Well, you suddenly disappear and something's coming at them. So the point there is that she hadn't told him, she didn't tell him where it was going to be coming from. He wasn't aware of it and reacted because he wasn't expecting that.
It may also be beneficial to prepare the individual to know what will be happening before arriving via a social story, which can be a video or storybook explaining what will happen when coming to the dental office. This is a simple social story. Occupational therapy students from DUville University have created several social stories that are available in our waiting room and our sensory gray room. Next, Simone is going to discuss our inclusive Give Kids a Smile event.
Hi, everyone. So the interprofessional connection between occupational therapy and dentistry is so important. This year, dental students at UB had the chance to work along with the occupational therapy students at the Buffalo Give Kids a Smile event through a new program of the Buffalo Give Kids a Smile, the Dental Carnival. In the next few slides, I'll talk a little bit more about the program that we created between the occupational therapy and dental students here at UB. So what is Give Kids a Smile? Give Kids a Smile is a program of the American Dental Association which provides oral health education, screenings, and preventative and restorative treatments to over 300,000 underserved children annually. This year, our Buffalo Give Kids a Smile offered both comprehensive and emergent care that was inclusive with the use of our language line as needed. Care was provided by the UB Pediatric Dental Club as well as our pediatric dental residents. We provided care for 81 patients, including those from Vive House, Sherman, New York Amish, as well as the uninsured pediatric patients of our Western New York community. This year was unique because in addition to the dental care that we provided, the occupational therapy students and dental students worked with Dr. Tona and Dr. Dion Wells to create an inclusive dental carnival, which included fun activities to enable individuals with IDD to learn about and become more familiar with the oral health and the dental setting. So each participant was met by an occupational therapy student who was matched with them specifically for the entirety of the program. The student was able to get to know each participant and direct them to their next room on their schedules. In each activity room, there were 2 dental students who were experts on running their specific activities. The first 3 rooms were flossing, toothbrushing, and our simulation room, which all focused heavily on oral health. The activities were created in a way which progressed from gross motor to fine motor skills as to follow a developmental sequence. For example, the OT decorated to look like The OT students helped us to start by having participants slide a rope between two chairs that were decorated to look like teeth. Then they strung between the elevated studs of large Lego blocks to remove Play-Doh, and then removed small amounts of Play-Doh between teeth of a typodont or dental model using floss. The OT students explained that the motor skills developed from gross to fine coordination, so they were able to stop the activity if an individual had difficulty at any level. In the simulation room, we gave each participant the chance to be the dentist. We instructed participants how to don PPE and enabled them to move the dental chair up and down, as well as to take a look inside of their patients' mouths. The next 3 activities included sleep health, nutrition, and social stories. Sleep health and nutrition are important for overall health. We created games which emphasize the importance of sleep and a healthy diet. Participants then had the chance to read social stories, which accurately displayed what to expect at the dentist's office. The dental office can be overwhelming for some patients, so the social stories can depict what to expect and help the patients feel more comfortable going to their future appointments. This year, Give Kids a Smile was even more special. Raven, one of our participants and recipients of dental care, will be receiving braces completely free of charge from Dr. Jim Gleason. The Give Kids a Smile Dental Carnival was a huge success and truly embodied the essence of inclusivity and interprofessionalism through the collaborative efforts of the dental and occupational therapy students.
Thank you so much, Simone. And thank you to everyone who presented. I know we have some questions in the chat. So let's take a look at those. So this one looks like one for Dr. Dion. Can these techniques decrease the need for sedation or anesthesia for patients with disabilities? We get that question a lot. Do you want to talk to that a little bit, Dr. Dion?
Absolutely, that is a huge and very important goal. Our waiting list for the OR, our waiting list for sedation is incredibly long and wide. And for our patients with disabilities, we finally have this collaborative experience to help us take a second look at those patients that are on the waiting list and an opportunity to avoid going to the OR. Let's work with occupational therapy. Sometimes these patients are going to the operating room for a cleaning or to get an x-ray. And if you continue listening to our stories, you'll see that with the help of the OT, we can complete that cleaning and we can get that x-ray. And so yes, that is the goal, to reduce the patients that are referred to the operating room and for sedation.
And another goal for us from occupational therapy is to not be needed all the time. We want the hygienists and dentists to learn the techniques that we use and to understand when to use them. And most of the people that we work with, say that they've learned a lot. And I think one of the best stories for me was a story that Dr. Dion told me a few weeks ago about a patient who came in, do you remember, that had a lot of stain on their teeth? Do you remember that story? And then she said, you weren't there and I wasn't sure what to do. It was a patient with cerebral palsy and we were getting ready for sedation because we really thought that they had this mouthful of caries. And we were filling out the paperwork, and then I did some of the deep pressure that you do, and I tried the face stuff that I've seen you do, and then I was able to get the patient's mouth open for the first time, and there were no caries at all. It was
just staining. That's right. I think that was was it Meredith that was there with us for that patient case? One of the residents took a look and they just were so convinced that it was caries and that this patient, we were filling out the paperwork, and you just have to remember what I saw the OT do and what we were taught. And after taking a second look, it was intrinsic staining. And so, here's a parent. Now I have to talk the parent down from, no, it's not caries. Let me show you again. But that was a wonderful story. And I think your OT students would always tell me that's one of their favorites as well.
Yeah. Dr. Wong?
Well, thank you very much. Excellent presentation, everyone. I just wanted to also augment the fact that a lot of these cases don't need to go to the operating room all the time, along with OT, but also behaviorists. Behaviorists have a very important role in helping us collaborate to make the patient successful for a lifetime of care, not needing general anesthesia or sedation. So our goal as professionals is to help people meet their challenges and overcome their challenges and thank you for what you're doing. So I just wanted to add that to the topic.
Yeah, we do a lot of presenting with speech therapists and behavioral specialists, and really everyone has a role to play. There's a whole team that are out there to help you. I do a lot of interprofessional work with dental students, and they often say, we're glad, we didn't know there was a whole team out there. Like, we're so glad that there are all these people to help us. And I hear the same from medical students. So everybody has a part to play, and hopefully we can all work together to do the best for patients.
Yeah, I think this is a very valuable presentation, especially from the medical side. We don't always know what goes into helping these patients, so it's very valuable for us. We have a couple more questions. Looks like we have time for two. So Catherine Bridges wants to know, can you outline the path that one would take in occupational therapy to be able to work in this type of collaborative environment? Like, what would that look like to get to what you all do?
So I will tell you, there is nothing that I do or that our students do that isn't basic pediatric OT. So I think any pediatric occupational therapist or occupational therapist that works with developmental disabilities can work in the dental office if you are willing to work with them. Because the trick is, I didn't know until the first time I walked in and sat down and observed. I had no idea what the needs were. Once I saw the needs, I was able to say to Dr. Dion and the hygienist, hey, this is what I think I could do to help, but I'm not sure if it's really helpful. What do you need? How can I help? And we work together all the time. I had no idea what a rubber dam was, or ISO-Lite or any of those things. And every day I learn, and every day she learns, and we learn together. But the OT skills themselves, they're really pretty basic skills. We did do two presentations for AADMD about a year and a half ago that are on the website that are pretty thorough. They really go through a lot of techniques, and they would be great for an OT to watch. And as I said, there's some research out there for OTs as well.
Thank you. And then the other question I think was also asked again was, how are you all coordinating the dental and occupational therapy side with Medicare and Medicaid reimbursement? Just wanting to know, what does that insurance coverage look like for both of the professions in one visit?
So this is an area that we are really working on. We really don't have coverage for OT right now in the dental office, or at least we haven't started billing yet. We are looking at our outcomes at this point with and without OT to see if we can show that exams are more successful with OT there. I think if we can show that, we can start to make some inroads to get insurance reimbursement. Right now, though, University Pediatric Dentistry just hired a full-time OT just because they found it that beneficial. But we know that reimbursement is what we really need to be sustainable. Dr. Dion, do you want to add to that?
Yeah, I'll just add that we were lucky to get some funding from DentaQuest for our desensitization or intervention room. But other than that, it has been pretty much the heart of Dr. Paul Creighton saying, listen, I believe in this program. I see the difference it's making. Like I said, we've been working with the population with disabilities for 25 years plus, and we have, it's terrible to say, but it's always been this work in progress, and now we're seeing the light at the end of the tunnel, that just like you're saying, one day, not that we'll have to have an occupational therapist, but that we can learn techniques to care for these patients in the most comfortable way. But for now, yes, we are racking our brains as to how do we bill for this. And if anybody out there has ideas, yes, Alan, tell us.
Yes, the AADMD is trying to work to help advocate for such for occupational therapy, but in some states they have behaviorists that you can bill for this. But in dentistry as well, there's a behavioral code, behavioral guidance, a D9920 code that we're working at. And in California, we're able to charge for extra time for behavioral management of those with any kind of restrictions, either physical, emotional, developmental, intellectual. So that's sort of an additional fee code if you describe it well. And they're working on it with the Medicaid system as well, Medicare system. So there's light at the end of the tunnel, but we have to work together and champion and speak for one another so that we can support our patients that require a little bit more adjusted time instead of rushing them and treating them as an individual.
Well, thank you so much, Dr. Wells, Dr. Tona, Simone, Meredith, and Heidi. I think this is a very great conversation. And I will turn the mic over to Dr. Wong to tell you about our conference.
All right, great. Again, thank you, panelists, for a wonderful presentation. I'm looking forward to seeing you some in Orlando. And Ademiola, you did a fantastic job as always. I want to also thank Cindy Lee, who is also a VGR presenter, speaker, and John Hood and Courtney Frey in the background, and Jamie as well, helping with the background, and Dr. Ben Warner, our faculty advisor. So AADMD has 3 tenets. One is advocacy, education, and access to care. And we have our meeting coming up this June 3rd to 5th in Orlando, Florida, at Walt Disney. And it's going to be a fabulous conference with a lot of speakers. And the theme is moving forward. Now that we've had pandemic, how do we move forward to improve the lives and the individuals? And we're focusing on sleep and sleep disturbances. So we have a monograph that we'll be presenting. I think we're going to show you slides of our conference, and it's right a precursor to this world. And just like we collaborated here tonight, our goal is to collaborate. We have the president of the American Medical Association, the president of the American Dental Association, the National Council on Disability, several other presidents of different organizations talking together and how we work together and maybe move occupational therapy forward and other healthcare organizations as well. So it's all about improving the lives collectively. I want to thank all the participants for joining us tonight. Hopefully I'll see some of you in Orlando, if not physically, maybe virtually. So check out our website at aadmd.org or the aadmdconference.com for our meeting. This presentation will be available on our website at a later time. And let's see, I just want to, again, thank you everyone for being here, and thank you our presenters, and Courtney, Jamie, and John for being in the background, Dr. Ben Warner for being our faculty mentor, and Ademiola and Cindy for being our coordinators. So have a great night, everyone. Thank you again.